Welcome to this highly detailed explainer, where we're going to break down every single clinical nuance of subdural hematomas, or SDH, in CSF shunt patients. We are going to go through this point by point, skipping absolutely nothing, to make sure you get a crystal clear, comprehensive understanding of these specific complications. So, get focused and let's dive right in.
Section 1. The mechanics of shunt SDH.
So to really understand this, the fundamental pathophysiology we have to grasp is that this condition is driven by a mechanical collapse of the brain parenchyma. When cerebral spinal fluid is shunted, that sudden or excessive decompression can literally cause the brain to shift or collapse away from the skull. And as it pulls back, it yanks on and ultimately tears those vital, incredibly delicate bridging veins. And that is exactly what leads to the hematoma. The whole clinical picture here is captured beautifully in a quote right from the medical literature. It revolves entirely around an, quote, extremely delicate balance between subdural and intraventricular pressure. It's basically a high-stakes game of pressure gradients. If the intraventricular pressure drops too low, that subdural space expands, and it sets the perfect stage for bleeding. But beyond just general brain collapse, we have to watch out for a few specific anatomical vulnerabilities. For instance, elderly patients with severe brain atrophy. They are at a much higher risk because their bridging veins are already stretched out. Plus, simply having the patient stand upright can create this dangerous siphoning effect, which generates negative pressures in the ventricles. Interestingly though, while the SDH risk is high, the data shows there's actually a very low risk of developing an epidural hematoma following shunting. Section 2. Incidence and risk factors. Let's look at the actual numbers. The incidence rate in adults following shunting is surprisingly broad, landing anywhere between 4 and 23%. That is a pretty significant chunk of your adult patient population that's going to require really close post-operative monitoring.
But then, contrast that immediately with pediatric patients. The incidence drops significantly to a much tighter window of just 2.8 to 5.4%. The physical mechanics of a child's skull and their developing brain just react completely differently to pressure changes than an adult's does.
Now here's where it gets really interesting. There is a stark contrast when you look at the underlying conditions. If a patient is being shunted for normal pressure hydrocephalus, they carry a massive risk of developing an SDH. We're talking anywhere from 20 to 46%. But on the flip side, hypertensive hydrocephalus carries a drastically lower incidence rate of just 0.4 to 5%. So the underlying pathology completely alters your patient's risk profile.
We also absolutely cannot skip the major structural risks that come with long-standing hydrocephalus. Think about children initially presenting with macrocephaly and large ventricles. They often have a very large head that houses very little actual brain parenchyma, leaving them with a thin cerebral mantle. Medically, this structural mismatch is called craniocerebral disproportion, and it skyrockets their SDH risk just because of the sheer volume of empty space that can form inside the skull once that fluid is finally drained.
Section 3. Fluid and collection characteristics.
You might logically assume the hematoma forms right where the shunt was placed, right? But the data actually tells a different story. Only 32% of collections are on the same side as the shunt. 21% are on the exact opposite side. And most importantly, a massive 47%, nearly half of all cases, are bilateral. This fundamentally changes how you approach this. You always have to image the whole brain, not just the hemisphere where you place the shunt.
So when we finally discover these collections, what are we actually looking at? Well, first, the timing is typically subacute to chronic. Anatomically, those previously large ventricles have completely collapsed by this point. And when analyzing the fluid itself, it's almost never colorless. In fact, only 1 in 19 cases show clear fluid. Crucially, for your lab testing, every single case showed elevated protein compared to normal CSF, even in those rare clear samples.
Section 4. Indications for treatment. The established protocol gives us a few really clear pathways to follow. For small, totally asymptomatic collections under 1 to 2 centimeters thick in patients who have closed cranial sutures, the recommendation is conservative. You just follow up with serial imaging. However, symptomatic cases, which make up about 40% of cases and often present with symptoms that look exactly like a shunt malfunction, those absolutely require treatment. Also, children with open sutures should be treated proactively just to prevent the development of macrocrania or any delayed symptoms down the road. Now, you are definitely going to run into a major clinical controversy when you're facing large, entirely asymptomatic collections in older children or adults. Do you just ignore it completely, or do you go in and intervene? The medical literature is totally split on this.
Many experts firmly recommend not treating these asymptomatic lesions at all, literally regardless of how they appear on a scan. On the other side, you have practitioners who vary their recommendations entirely based on things like the size of the lesion or whether it looks chronic, acute, or mixed. It remains a highly debated gray area in neurosurgery.
Section 5. Surgical treatment techniques.
If you do treat, the gold standard surgical approach is a coordinated two-pronged attack. First, you have to physically evacuate the subdural hematoma using standard methods. Think burr holes for chronic collections or a full craniotomy for acute ones. But that is only half the job. You absolutely must simultaneously reduce the degree of shunting. This establishes a lower pressure in the subdural space compared to the intraventricular space, which essentially forces the ventricles to re-expand and stops the hematoma from simply filling right back up.
How exactly we reduce that shunting really depends on the patient. For your shunt-dependent cases, you have to increase the system's overall resistance. You can upgrade to a higher pressure valve, or if they have a programmable one, just increase the setting. Alternatively, you can insert a Portnoy device to toggle the flow externally. Just a massive caveat here. If you use a Portnoy device, it is absolutely critical that the patient's caregivers know exactly how to reliably open it in an emergency.
Conversely, if the patient is non-shunt dependent, you have slightly more aggressive options on the table. You can certainly use any of the methods we just outlined, but you also have the option to temporarily tie off the shunt entirely, just completely stopping the flow for a set time. Or you can insert an anti-siphon device to counteract those negative pressures we talked about earlier when the patient stands up.
Another distinct, highly specific technique is establishing direct drainage of the subdural space itself. Surgeons might drain that space into the cisterna magna, or route it all the way down to the peritoneum by creating a subdural peritoneal shunt. This is typically done using a low-pressure valve, or sometimes even no valve at all. And believe it or not, some authors in the literature actually suggest having the caregiver frequently pump the subdural valve manually just to ensure continuous drainage.
Section 6. Achieving the delicate balance.
When it comes down to it, every single surgical adjustment, every valve upgrade, every millimeter of fluid drained, it's a high-stakes tightrope walk. Lean too far to one side, you get undershunting, where you restrict the flow too much and produce symptoms of active hydrocephalus, putting really dangerous pressure on the brain from the inside. Lean too far to the other side, and you get overshunting, where you drain too much fluid, collapse the brain further, and actively promote the return of the exact same subdural hematoma you just spent all that time trying to fix.
Because this balance is so incredibly fragile, the source text explicitly warns that physical recovery has to be strictly and patiently managed. Quote, following surgery, the patient should be mobilized slowly to prevent recurrence of the STH. Rushing a patient back to their feet too soon can instantly reintroduce that siphoning effect, undoing all of that complex surgical balancing you just achieved.
We've thoroughly unpacked this point by point, the mechanics, the statistics, the fluid markers, the heated treatment controversies, and the exacting surgical techniques, all straight from the foundational literature. With every granular detail covered from pathophysiology to postoperative care, my final question to you is, how will you apply this delicate balancing act in your own practice? Thanks for joining me on this explainer, and keep learning.